thank you for having me. This has been a story that I'm continuing to learn about. Since about 2015, I was given the task. I was a public health physician working in Counties Monaco, and was given the task of, hey Simon, the hospital's overflowing, what can we do about it? And that set me on this pathway to look at scabies and its connections. So I thought I'd try and cover quite a lot of stuff that I covered in about a day yesterday. Try and cover that in about 40 minutes today. Why am I interested in scabies? What the traditional views of rheumatic fever causation are? Evidence that scabies and rheumatic fever are linked. Some of the evidence for benefits, health benefits from treating scabies specifically. One of the major issues that we've found with scabies is that the diagnosis is often confusing and difficult. So we've had some conversations with paediatricians in Australia about how best to diagnose scabies, so I'll try and convey that information. Some of the clinical features, crusted scabies, main differential diagnoses, and there's recently some consensus criteria around the diagnosis. And then some of our research related to a high prevalence, unexpectedly high prevalence in New Zealand. And also some of the things that we're doing, PCR tests for scabies now, also some of the research looking at the connection between scabies and rheumatic fever. So who am I? I trained in medicine in Auckland, and I was initially doing adults, and then decided I'd cross over into public health, did a PhD in epidemiology, got interested in sugar, done quite a bit of work with Kohate here, and quitting smoking, and then just completely by hazard I got interested in scabies, and I worked in Middlemore for some time and had scabies myself probably about 10 times, and always had difficulty with the diagnosis. Sometimes between me and my wife, who's a paediatrician, sometimes she would disagree with me, but when we were both itchy, it was kind of obvious what was going on, but often I'd have to have difficulty with the GP convincing him that we actually had scabies, and often I had to kind of almost twist his arm to get some treatment. So my experience was that I didn't have all the typical signs that I'd see in the textbook, like burrows and delta wing signs, mites. I just basically had little spots on the arms and legs, and often difficulty with the medical profession. And also my daughter started getting side effects when we used permethrin. She get tingling around the mouth, and so it was even more difficult to get ivermectin. And so I think most of you are probably familiar with the New Zealand situation in terms of how we see the causation of rheumatic fever is mainly related to Group A streptococcus, infection in the throat. There's a little bit of a suggestion that it's also related to the skin. What I found was that going to Darwin and talking about scabies and rheumatic fever was actually quite different. There was, in the first slide in the Darwin presentation, they talked about scabies having its own issues, then leading to impetigo. Also these immune-mediated issues, rheumatic fever and glomerulonephritis. So this is published in The Lancet by paediatrician Dan Engelman. So I think that was within a week of me presenting some information about scabies and rheumatic fever at Middlemore and only being given 3 minutes to present and not a very receptive response. So some of the things that I saw when I was initially starting to look at this, these are scaled diagrams, by the way. This was an Australian survey of scabies and impetigo in Fiji, and basically they reported a relative risk of 56. If you had scabies, then your risk of impetigo was 56 times higher. And so basically what they were saying was that almost everyone in that survey in Fiji who had scabies also had impetigo. So the two are almost hand in hand. But when I looked at what was happening in New Zealand, it was all about antiseptics, antibiotics for impetigo, which caused me to question, is scabies a little bit more common than we think? My next little study on the scabies road was going into a childcare centre in Otara, and at that stage I thought the dermatologists were the experts on scabies, so I brought a dermatologist, a GP and a nurse all into the same childcare centre, and this is this is the entire group. This is the proportion who were diagnosed by the GP with scabies. This is the proportion here who were diagnosed by the nurse with scabies, so it wasn't the same kids. And what about the dermatologist? The dermatologist said none of them had scabies. And that surprised me because the kids in the room looked very like they had lesions very similar to what I had when I had scabies. And then I applied retrospectively the IACS criteria, which I'll talk about later, and actually almost all of them met the criteria for scabies, the clinical criteria. Just briefly, one of my early studies was to look at a cohort of patients who'd been enrolled in the government dental program and looked at evidence of whether they had scabies either before enrolment or after enrolment from hospital diagnosis. So that, I mean, most scabies are not diagnosed in the hospital, but there's a little bit that is. And looked at the risk of rheumatic fever, and this plot almost made me fall off my chair because the risk of scabies, of rheumatic fever in those with scabies after their first dental appointment was about 27 times those with no evidence of scabies. And when I looked at the hospital records, many kids were coming in diagnosed with rheumatic fever and diagnosed with scabies on the same appointment. That didn't get widespread uptake, so I thought, well, people get more convinced by maps these days. Let's have a look at what's happening with scabies and rheumatic fever. So permethrin I could access through Farms Warehouse, the dispensing records in New Zealand, the government-funded dispensing records. And so the dark areas here, such as Mangere, Otara, Gleneagles, parts of West Auckland, where there's a lot of permethrin going out. And the open circles here are the addresses of rheumatic fever cases at the same time, and you can see that basically this is one of the strongest geographic statistical associations I've ever seen in my career. The tricky thing is that if you look at where Pacific people live in Auckland, it's also strongly associated. If you look at poverty, it's also strongly associated, but when you tease it out in the regression model, you actually still see a very strong association between treatment for scabies and the incidence of rheumatic fever. Even when just recently we've been looking at the Bradford Hill criteria for scabies and rheumatic fever, just plotting the prevalence here of scabies, and this is the prevalence of rheumatic heart disease, which is an order of magnitude lower, but a 10-fold increase in scabies prevalence correlates with a 10-fold increase in rheumatic fever prevalence. One's per 100, the other's per 1,000, so there's a difference in magnitude, but certainly a very, very strong relationship, and that simple linear regression model explains, I think, about 50% of the variation that's seen there. And obviously, very different definitions of rheumatic fever, different definitions of scabies, but still quite a strong relationship. One thing that got me very interested in scabies was seeing some of the benefits from the Pacific of improving treatment for scabies. And quite an influential study was one done by an Australian group, Lucia Romani, who's actually coming here in June. She led this study and basically had different policies in different islands in the Pacific, in Fiji. One was just usual symptomatic treatment with permethrin, screening and symptomatic treatment. The other one was mass treatment with permethrin. The other was mass treatment with oral ivermectin. So ivermectin, I believe, is not available here for scabies, but it's an oral drug. And certainly if I get scabies in Auckland, I want ivermectin. It's much simpler, very straightforward to treat. And so these are the results up to 2 years afterwards. And you can see that in terms of reduction in scabies, even just the standard clinical approach of identifying and treating had quite a major reduction, but more so when you do mass drug administration, so treating the symptomatic and the asymptomatic. And if you think about it, that's kind of the approach that we take anyway in clinical work, where we see a child with scabies and we recommend generally the whole family get treated whether they're symptomatic or not. But the highlight here is how effective ivermectin is in terms of a 95% reduction, I think, in 2 years. So these are obviously in smaller islands where there's not so much travel, people coming and going. It's a little bit easier to give treatment and deal with this, a fixed population, relatively fixed population. And this is what happens with impetigo, so evidence of bacterial infection. The latest stuff from Queensland shows that scabies is not just punching holes in the skin, it's also secreting proteins which interfere with complement. They've done work looking at what happens to bacterial growth there's an animal model of scabies. Human scabies only grows on humans, except if you give pigs steroids, then you can also grow it on pigs' ears. And they studied the change in the bacterial flora, and it changes from usual flora to staph and strep when the pigs get scabies. And we think that's mediated through effects that scabies has on innate immunity.
And just notice that all these studies done in the Pacific by the Australian group don't recommend the laundry stuff. So it's just the drug treatment. It's the laundry stuff, even though it's part of what is still Ministry of Health recommendations in New Zealand, is no longer recommended. And dramatic changes in prevalence, particularly in the ivermectin mass drug administration group. So what do we know about scabies? Well, it tends to burrow in the superficial layers of the skin, lays eggs, and if you haven't been exposed, tends to take about a month before people get symptoms, which is a hypersensitivity reaction. Something that I think is a little misunderstood in some communities is that there's an idea that it comes and goes from the animals to humans. But in fact, every mammal pretty much has their own mite. And so the dog mites, yes, they do cause mange or canine mange in pigs, but they don't. Those mites don't cross the species barrier. So just in terms of, we've taken a lot of effort in the work that we're doing in Auckland to study scabies prevalence, to try and improve the clinical diagnosis. So I'll just try and quickly convey what we do. We try and get a well-lit private space, headlamp basically. Symptoms are obviously important. Itchy, the child itself or the patient is usually itchy, although some people with chronic scabies, if they've had it for a long time, may not be itchy. Obviously, itch in the family is almost pathognomonic of scabies. It's often worse at night, can be generalised or localised. Other family members may have skin lesions. So when I first started talking to the dermatologist, it was all about hunting for burrows and mites. And then I sent the photos from the study that we'd done in Otawa. I sent those photos to a Melbourne paediatrician who sees a lot of scabies in Fiji and the Solomons, and he sent me a one-line email back saying, I've just come back from the Solomons, diagnosed 200 kids with scabies, haven't seen one burrow or one mite. So I got the impression that there's very different cultures of diagnosing scabies, even within, Australasian paediatricians, dermatologists. So we started looking at the Australian publications, and they're all about papules in an equal distribution, so basically on the arms and legs. So, or in a typical distribution, so mostly in older kids, it tends to be on the feet and ankles and on the back of the hands, but also around the abdomen. That's what we've been seeing a lot in our survey. Younger kids tends to be more generalised. Here's another picture of the typical distribution of scabies. In fact, the data seems to suggest it's more common around the ankles than it is around the hands. So this is what we've been looking for in our studies, our prevalence study that we've been doing in Auckland. We're looking for these little raised lumps, basically papules. Usually they're itchy. Often they're easier to feel than they are to see. So less than a centimetre in diameter, solid, palpable, elevated. Here's another example with a little bit of ooze and infection, some of these papules becoming pustules. We've been seeing a lot of this stuff with lesions around the volar aspect of the wrist. This is what we're seeing often in younger kids. This is what we're seeing often on the feet, these papules. So crops of these papules is what we call typical for scabies. And so the modern scabies criteria, IACS, International Alliance for Control of Scabies criteria, basically talk about typical and atypical lesions. And typical lesions are crops of papules in a typical distribution. So here's another example. Here's another example with some hypopigmented lesions suggestive of previous scarring. And obviously infection often goes with scabies. So here's an example here with some crusting and erosions suggestive of impetigo with these other scabies lesions. We did involve a dermatologist in the study who was very interested in seeing these little small scaly burrows, quite hard to see here. I must say I completely missed them. This is what we're seeing in, I hadn't actually seen this in the prevalent study because we're seeing mainly toddlers rather than infants, but this is a presentation more common in infants where you get a vesicular, almost chickenpox-like reaction. Just a few more infected scabies photos. We're often seeing a few lesions around the tummy button as well as on the arms and legs. Nodular scabies around the perineal region. Impetigo often associated, although we haven't seen that much. In New Zealand it seems to be the issue is mainly recognising the scabies. A lot of the infection seems to be treated. And of course this is more infected lesions with redness, swelling, crusting, pain, pus. Here's another example, scabies and impetigo. Another example, these are photos from the Aboriginal community in Australia. Excoriation is often common with scabies, so scratching, and that tends to mask the classic signs. So often we don't see scabies. So this is crusted scabies. Thankfully we haven't seen any in our school study, but often an issue for older adults, particularly diabetes and immunocompromised. Interestingly, yesterday when we were showing these photos, many of the nurses showed me some photos of patients in the community that had very similar looking lesions. So yeah, this I think seemed to ring a few bells. There's a few other examples of it. Depigmentation often common. We've seen a few cases in New Zealand. Often kids are getting treatment with steroids or calamine lotion or antihistamine, which often mask the signs of scabies. So you see a more generalised eczema with a few sort of focal patches. And we've had cases like this with PCR positive scabies. So the diagnostic criteria that we're using. The IACS criteria, I think, because it involves quite a lot of people that the Australian group have come up with. So there's confirmed scabies, which is what the dermatologists are looking for, which is very specific but not sensitive. They're going to be missing a lot of scabies. So this is looking for crops of papules in a typical distribution with itch and itch in the family. And that's what we're using in our studies. So a summary is that clinical scabies is itch and itch in the family with typical crops of papules, and suspected is itch and typical papules, or itch, an itchy family member, and atypical papules. So just one or two papules rather than the crops that you see on the photos that I've shown. We've also collaborated with a Queensland group to get PCR tests just using a flock swab, which you use for COVID or Mason with saline. It's only available as a research tool at the moment. But some very subtle lesions here, so you can hardly see them. This here, just one papule. Here there's a bit of broken skin, so not so surprising, but just very small, difficult to see lesions. We're getting scabies positive. Obviously the differential diagnosis is tricky. Insect bites usually have a central punctum and usually not so generalised as scabies are on exposed areas of the skin. So here's a summary of our survey of childcare centres and schools in Auckland. So we've had a very high prevalence. This is the total number of kids that we've seen. This is the number with typical or atypical papules. And this is the number with so this is the ones that fulfill the criteria, IACS criteria, and the yellow here are the ones that have PCR positive, and this group here are the ones that are on topical treatments, so mainly calamine lotion. This group here are on steroid treatment, so some of those PCR positive for scabies. So we think there's a bit of an issue with misdiagnosis in primary care. Many of the cases I call up the parent and I was expecting that they'd just never taken their child to the GP or the doctor, but many of them had recently been to the doctor but had been given other treatments. So that's most of the talk. So scabies, obviously itch in the family are the main history features. The examination looking for papules is important, and misdiagnosis is likely to be a major issue. And the connection with rheumatic fever, I think there's increasing evidence, statistical evidence, that scabies and rheumatic fever go together, and the evidence from other areas of the Pacific is that if you make an effort with scabies, you can get dramatic reductions in prevalence and also in bacterial skin infection. So very happy to be here, and thanks to Toa for collaborating with us. Happy to take any questions.